Good morning. Happy grand rounds of spring break. We are glad to be here. The coffee just arrived, so in the room, we're going to get coffee. So we're also testing if the sound works okay for those of you on Zoom, so hope that it does. I'll be monitoring chat, and we're very excited for today's discussion. So individuals will be coming back into the room. And I didn't prepare any jokes for this little lull here, but we're in great shape. So I will go ahead and kick us off with a few announcements. Next Grand Rounds is on April 4th. Brittany Highlander, one of the geropsychology interns at the GREC, and we're very excited about her talk related to diverse community outreach with older adults. So 2 weeks. Next Journal Club is April 11th. The presenters are Emily Stauffer and myself. You will receive opportunities to provide evaluations. I really highly recommend completing evaluations, especially for our geriatric faculty. It's so valuable to us to have those evaluations for important things like dossiers. So please evaluate well and positively. Okay, so as we are walking back in slowly, I'm slow walking the introduction, but Dr. Jacob Walker is our presenter this morning. He's going to present Aging with HIV, the role of geriatrics in the antiretroviral era. Dr. Walker completed his medical training at Boston University and his internal medicine residency here at University of Colorado. He then went on to complete a geriatrics fellowship and the first few years of his career at University of Chicago, where he also completed an HIV implementation science fellowship. He returned to the University of Colorado in 2022 as assistant professor in geriatrics and specializes in the care of older adults living with HIV. He'll tell us about his work, I assume, in the Positive Aging Clinic within HIV Clinic. His work focuses on helping HIV clinics adapt to a growing number of older adult patients through an implementation science lens, with particular interest in creating a more dementia-friendly healthcare system. So we are now all very excited for Dr. Walker's discussion this morning.
Thanks, everybody. Please keep getting food and coffee. I stepped away during my own introduction to get it. So I get asked to give talks on HIV and aging a lot because it's a fun, unique thing that I do. And it's always a little different for every audience. And I asked many members of this audience what they want to hear about. And I got like 20 different answers. So I'm going to try to cover a lot of different ground because you guys are very curious people. But I'm going to try to focus it on some of the important demographic shifts and why this is important, as well as the mechanisms of early aging faced by folks living with HIV. I'm going to use that to reframe HIV care as just one case study for how we as geriatricians can be involved in complex disease management and how we can facilitate uptake of geriatric clinical care tools using HIV clinics as a model. And that's really a long way of saying, what the hell has Jacob been doing and why? Because Dan let me in without giving a job talk. So very quick refresher. HIV, it's a retrovirus, chronic infection infecting human T cells, affects the immune system, leading to a condition known as AIDS, defined by a CD4 T cell count less than 200, or the presence of an AIDS-defining illness, including many opportunistic infections or unique cancers. We have two major therapeutic goals. Undetectable viral load, so getting that HIV viral load down to 0, which also makes it untransmissible to sexual partners, and immune reconstitution, so getting that CD4 count back up as high as we can so that people can fight off infections. And we're doing that with a lot of different medications. This can be overwhelming. People think, oh my gosh, HIV medicine, that's really complicated. It's not actually. We only use a few of the tablets on this big chart here in usual clinical practice. And I really like to highlight to patients, we have so many options. There are single pill regimens. We have long-acting injectables. Like, this could not get any better. This is a huge accomplishment. For those who are curious, the vast majority of patients are going to be on single pill regimens listed at the top here that contain 2 to 3 drugs from 2 to 3 different classes. Most of them use an integrase inhibitor, one of our newer classes, as their backbone. The long-acting injectables, which are newer in the field, are also based on integrase inhibitors. But if we need to switch things around for viral resistance, side effects, costs, we've got a lot to choose from, which was not true 30 years ago. This has led to a surge in the older adult population, not just living with HIV, but living longer with HIV. There are over 8 million people worldwide over the age of 50 living with HIV right now. That has doubled in the last decade. This is true for US numbers as well. And that is largely because of the introduction of we don't use HAART very often. I forget what it stands for. Highly active antiretroviral therapy in 1996, based on a combination of 3 different drug types, with the introduction of protease inhibitors that we still use for fighting COVID today. But that is what has led to this surge. And that is what led to the peaks of AIDS-associated deaths in 2004, which is a lot more recent than some people realize. Some people put the pandemic like farther back in their mind, further back in history in the late 80s, early 90s. But globally, it's an ongoing problem with over 600,000 deaths from AIDS-related illnesses in 2022. When I asked some of the folks in ID Clinic what they want me to tell you, this was their one ask, so I'll put a plug in here that even though the reason people are living much, much longer with their HIV in this population is aging is because of effective treatments, it is worth noting that adults 55 and over make up about 10% of new diagnoses, and their one ask from me to you is please screen your patients. Anyone who is sexually active, potentially at risk, just screen for HIV. It's very easy, it's good to find so that we can treat it. What's more concerning for me in practice, and I'll get into this in a little bit, is that adults over 55 are much more likely to present with advanced disease because they have not been screened. So we see people with much lower CD4 counts, more opportunistic infections, greater prevalence of AIDS. This is a success. We are down from 16% of new diagnoses being older adults just 2 years earlier. So keep up the screening. Focusing in on the US, this is the latest data we've got from 2018. It was around then that we hit the point that over half of people living with HIV in the US were over the age of 50. The fastest growing group is those in the 65 plus range. For a little bit of number reference, from 2017 to 2021, we went from 90,000 people to 150,000 people living with HIV over the age of 50. So that's nearly doubling in about a 4-year period. I think what demonstrates this rapid growth a little bit better is growth of older adults within the Ryan White HIV/AIDS programs. So the Ryan White program provides direct medical care, medication coverage, and support services to about half of everyone living with HIV in the US. They're sort of the payer of last resort, making up about 2,000 providers, annual budget of $2.3 billion. And as you can see from 2010 to 2020, that age curve has shifted dramatically to the right, with more and more people filling the 55 to 64 and over 65 buckets. So this is not just a matter of, oh, we have to manage older adult problems in the clinic. It's now a major policy concern. We have lots of money being funneled into HIV clinics that are providing all sorts of primary care, not just HIV care, and they need to know what to do. So the numbers are growing fast. In conjunction with that, we have a phenomenon in which adults living with HIV are aging faster. You hear a lot of different terms thrown around for this. They're aging quickly, they're aging faster, they're experiencing inflammaging, they're experiencing chronic aging. I don't love all of these terms. They sort of gloss over the root of the problem in the same way that saying the silver tsunami does. But it is true that HIV leads to a chronic inflammatory state. Even well-treated patients experience some of the cellular changes we also see in aging at much younger ages. This is often coined inflammaging. Some examples of this are increase in pro-inflammatory markers and markers of coagulation. We see earlier immunosenescence of T cells with a greater proportion of CD8 cells. We see more microbes getting across the gut wall. We see telomere shortening, especially in T cells, and loss of lymphoid tissue architecture. If I grab 90-year-olds from our clinic and looked at all their cells under a microscope, I would see these changes. I'm going to see these changes in 55-year-olds or 60-year-olds living with HIV. So hallmarks of aging occurring at much younger ages. I like this figure because it demonstrates how it's not just happening in a vacuum. We're not just seeing inflammaging. Adults living with HIV are also dealing with high rates of co-infections like Hep C, CMV, and HPV. We experience higher rates of comorbidities, high levels of stress and stigma, more frequent substance use, especially tobacco use, and some of the effects of our older HIV medications. So this example on the right is looking just at cardiovascular disease and the development of atherosclerosis. Not only do we have this chronic inflammation and this procoagulation state, we also have the effects of combination antiretrovirals, such as our older protease inhibitors, leading to dyslipidemia and endothelial dysfunction. And then we see higher rates of smoking and hypertension, leading to more inflammation. The result is higher rates of atherosclerosis, as well as unique types of atherosclerosis in which people have more and more non-calcified plaques. So it creates an entire milieu based around this chronic inflammatory state that leads to more and more problems as we age. Those problems manifest in usually one of two ways: models of accentuated aging or accelerated aging. So the accentuated aging is higher incidence of age-associated diseases. We see this especially with our cardiovascular diseases in people living with HIV, such as heart disease and stroke, in which the onset of heart disease, the onset of first stroke, is usually happening about the same age as peers without HIV, but at much higher rates. Or we see accelerated aging models, especially with many of our endocrinopathies, in which people experience a younger onset of an age-associated disease. So we see much earlier onset of menopause in women living with HIV. We see earlier onset of frailty. We see much more osteoporosis. I'm going to run through some of these examples just to give you an idea of what folks are facing. This is probably my favorite pair of figures. Looking at men 40 and over within the multi-center AIDS cohort study and tracking gait speed and grip strength over time, we see early divergence of both gait speed and grip strength in the 40s and 50s, leading to about a 10-year difference, especially on the gait speed side. By the time someone hits their 70s and 80s, the average gait speed of a 70-year-old living with HIV looks about the same as an 80-year-old living without HIV. This effect is greatest for those living with a higher cumulative viral load. So those who had more time experiencing HIV before we had treatments or more time off of treatments. The more years that you have replicating virus, the more likely you are to experience a rapid decline in grip strength and gait speed, two of our measures of overall strength and frailty. This translates into a high burden of geriatric syndromes in people living with HIV. So this is a slightly different cohort, but also men living with HIV based out of San Francisco. SCOPE cohort is a observational prospective study of volunteers. The median age of this group is only 57. Like, that's pretty young. And yet we're seeing about 10% of patients is frail, more than half is pre-frail, large number of ADL losses and IADL losses. A quarter had fallen in the last year, high rates of cognitive impairment, depression, and other functional impairments such as visual impairment and hearing loss. So pretty high. I think the ones that jump out to me the most on this are the cognitive impairment being around 50% and the fact that a cohort of people age 57, more than half are pre-frail. It's fairly impressive. One consequence of this accelerated aging is osteoporosis. For reasons we're not quite clear, the risk of fracture may double in folks living with HIV. It is not fully explained by differences in bone mineral density or by the earlier onset of menopause that we see in women living with HIV. The result is a recommendation that we screen at age 50 for both men and women. That recommendation is a little old. It may be that this is being driven by some of our older medications we no longer use. So if we relook at these numbers in another 10 years, we may be able to loosen that a little bit. But it's still one of the most frequently missed things that I see in HIV clinics. Bisphosphonates are the preferred treatment still. However, because of this being a unique population in which we don't normally screen, especially men, it can sometimes be hard to get bone mineral density screening covered. So I'm often just left relying on a FRAX tool to guess how at risk someone is, a tool that does not include HIV as a risk factor. Again, part of the reason for this osteoporosis risk may be some of our older meds. some in the room were practicing in the mid-90s when HART was first introduced. Those regimens were awful. It was 20 pills a day, taken sometimes 4 times a day, lots of drug interactions, lots of side effects. Patients will like show off their old pill bottles that they were using when they were 22 just to keep track of their medications for like a single illness. And today, as I showed you, we have as little as 1 pill once a day delivering multiple drugs. I'll bring you back to this slide. Again, huge accomplishment. I not only love that this is colorful, it just shows like so many years of scientific progress all in one table. But having long-acting injectables, where you're getting an injection every 2 months to manage your HIV, or a single pill with 3 drugs in it once a day to manage your HIV, means that polypharmacy in adults living with HIV is now dominated by non-HIV meds. So this is a sample of adults over 60, also in San Francisco. And this is a little bit older, this is from 2013. So our HIV medication regimens have improved even further since then. And at that time, about 100% of patients were experiencing polypharmacy as 5 drugs or more. And even if you took their HIV medications out of the equation, about 75% were experiencing polypharmacy. Again, this is people 60 and up, so a little bit younger than we see in clinic as well. What I want to highlight from this data is the amount of drug-drug interactions. So even in 2013, with some of our newer regimens, HIV meds do remain fairly interactive. Looking across different cohorts, we see anywhere between 30 and 70% of patients being prescribed meds with at least a moderate level of interaction inappropriately. An example of what this might look like in practice, if any of you are seeing folks with HIV, this is sort of the one takeaway I want you to remember, is the level of interactivity. This is just looking at how some of our HIV drug classes interact with statins. And as we see, there are entire classes of HIV meds that interact widely with statins. We really can't use a simvastatin or lovastatin with any of our boosting agents. We can't use ezetimibe with many of our older drugs as well. There's a lot of options. Again, we're blessed to have a lot of different HIV med options and a lot of cholesterol lowering options, but there's a wide number of interactions. I put a QR code up there for the Liverpool HIV drug interaction checker. If you want to check out my favorite drug interaction checker, they also have one for COVID drugs and they have a friendly app. So free plug for the University of Liverpool. Now, my particular area of interest when we're talking about geriatric syndromes in people living with HIV is cognitive impairment. It's one of the things people are most curious about, especially patients. People with HIV notice a lot in themselves and really want to know what's going to happen to them as they get older. It's sort of one of the top fears that people will express, is that no one will be able to take care of them or that they will develop dementia. Part of what's informing that fear is that they've seen HIV-associated neurocognitive disorders in peers, especially in the 90s and early 2000s. Now, HIV-associated neurocognitive disorder, or HAND, is a broad spectrum of illnesses that can span from mild cognitive impairment to severe dementia. There are a few other terms you'll see thrown around, like HIV-associated impairment, mild HIV cognitive impairment. I like HAND as just sort of the umbrella term that I use with all of my patients. And I explain that it can present in a lot of different ways, but thanks to antiretrovirals, most HAND now falls into the mild cognitive impairment category. We used to see people with fairly advanced dementias at very young ages, living in nursing homes in their 20s because of HIV they contracted in 1988. With treatment, we rarely see that anymore. I'm sort of set up to be the person that sees all of those cases, and I've seen like 3. So to give you a sense of how rare it is to see a full sort of advanced HIV-associated dementia nowadays. That being said, any amount of cognitive impairment is distressing to patients, and rates of HAND may be as high as 30%, even in the era of great treatment. This is due to a mixture of people having years off of treatment, so years before therapy, taking its toll on their cognition and their brain health. And the CNS remains a reservoir for HIV replication. So even with great treatment, some people will still see increased viral replication in the CNS, inflammation in the CNS that may be what's leading to this cognitive impairment down the road. What does this look like? So hand is usually a chronic mild cognitive impairment. It can present rapidly as an HIV encephalopathy. And so when I have residents on ACE and they're like, wow, this patient's confused, I guess I'll check a TSH and a B12 and a syphilis screening and an HIV. And we kind of just go through the motions. You can find it. So please keep checking those things. It is classically a subcortical impairment, which makes HIV-associated cognitive impairments really interesting. It's features kind of slowed processing, decreased attention, a lot of depressive symptoms of psychomotor slowing. It really looks like people are kind of talking to you through molasses. When you see a more advanced case, it's kind of remarkable how different it can be from Alzheimer's or vascular dementia. The MRI on the right is from a patient of mine who talked just like that. It was 3 seconds to respond to your questions, and every sentence came out like this. What we see on MRI are patchy foci of sort of T2 flare in the periventricular areas. You've probably seen hundreds of MRIs like this because it looks a lot like vascular disease. So not really a useful diagnosis based on imaging. We also can't really rely on the CSF to tell us whether or not HIV-associated dementias or encephalopathy are present, because we'll see viral replication even when people are well treated. So the amount of virus in the CNS doesn't really tell us, doesn't really correlate with the degree of cognitive impairment. The only effective treatment is antiretrovirals, and the blessing there is that it is one of the only kinds of dementia or cognitive impairment that you can actually dramatically improve with a pill. I use that to try to motivate patients who are experiencing some mild cognitive impairment from their HIV, that thanks to their efforts, thanks to this pill they're taking every day, they are keeping their cognition as healthy as they can. And then we go into all of the other things they can do, like exercise and eating well and socializing. If you're ever unsure about what you're seeing in a patient with HIV, whether this is hand or Alzheimer's, the most helpful thing you can do is send them for neuropsych testing, where it's easy to pick up on this subcortical impairment versus the more cortical impairment we see with Alzheimer's disease. With high rates of cognitive impairment, advanced care planning becomes very important. However, advanced care planning is rarely done or not done as often as it should be in HIV primary care clinics. There are a lot of very justified barriers to this. Providers often don't feel comfortable talking about advanced care planning. There are extreme time limitations. We're also seeing a patient population with very fractured social networks, people who may not have family or children that they can rely on as their proxies. This is also an opportunity for resilience. We see people with these really robust social networks, not based on familial linkages, so there's a lot of positives here too. But it means that we see pretty widely variable advanced directive use amongst people with HIV at any age, especially for poorer patients, racial ethnic minorities, and socially isolated patients. Our ID clinic is at 44%, not strictly our HIV patients, but all comers. So we're at the higher end of that range, but still pretty low for a clinic providing primary care. And again, part of the reason for this, why ACP is difficult, why people don't have time for it, is that they're dealing with a lot of other stuff that we don't have to deal with. So these are just some of the health maintenance items that we might not think of as often in a geriatrics clinic that people have to pay attention to every day in an HIV clinic. So we've got other co-infections and frequent STI screening to be done, higher rates of many comorbidities like depression, hypertension, substance use, hypogonadism. We've got a whole separate vaccine schedule we've got to pay attention to, including new ones being added every year, like more COVID vaccines with a different schedule and monkeypox vaccines. And then we have to be more attentive to cancer screening. So we have to maintain a higher suspicion for our AIDS-associated malignancies. We have to be more attentive to routine screening for cervical and lung cancer, which have higher rates. And then we also have to worry more about anal cancer screening, something we don't do in a general population. So this is why they don't have time for as much advanced care planning, and why I think there's a lot that we could do as geriatricians. They're seeing ACP barriers, multimorbidity, complex support networks, use of specialized drugs and lots of polypharmacy, cognitive impairment, high rates of depression and stigma, and then early frailty and osteoporosis, which may look familiar to a lot of us. That's the 4M framework. It's because so many of the problems that we see in people aging with HIV align so well with geriatric interests that we see a lot of funding opportunities, thankfully, from a wide range of agencies. So the NIA cares about this both from a healthcare utilization perspective and from that early aging, like mechanistic model perspective. We see funding opportunities from the CDC, from HRSA, et cetera. There's a lot of interest in trying to address the 4M specifically in HIV because they are such a high need population. That is where I bring some of this implementation science into it. So as Hillary mentioned, I completed an HIV implementation science fellowship while I was at Chicago. I believe it was a CDC funded program. The high interest in implementation science and HIV stems from the fact that we have lots of interventions. Not only that big chart of pills that I showed you, but we have whole new methods of treatment and prevention. We have PrEP, we have public health messaging like U equals U that needs to get out there. We have at-home testing, next-gen sequencing, network analyses, long-acting antiretrovirals. They've just got this whole suite of awesome tools that we need to get out there fast to keep HIV from spreading and help effectively treat people who are living with HIV. Yeah, so there's a lot of interest in taking those evidence-based practices and bringing them into routine practice quickly. And going through all of those sessions in that fellowship, I was like, man, I'm jealous. Why they have all these cool, fun tools. And if you take a second and step back, you remember, like, so do we. We have a lot of great shit. We've got pocket talkers, e-prognosis, exercise programs, cognitive screening, frailty screening, advanced care planning. There are a lot of evidence-based practices that we do every day that also lend themselves well to being rapidly spread through other clinic models. An extra advantage in HIV care is that their setup, especially in Ryan White clinics, looks a lot like ours. So it's this very similar environment. We have a multidisciplinary supportive team. In the case of Ryan White clinics, there is funding set aside for behavioral health, for care navigators. Most HIV primary care clinics also have access to pharmacists because they need to navigate the specialty drug programs that are out there. So it's a good setup for a testing ground of geriatric interventions because we have those team members in place already. How do we do this best? People have tried a lot of different ways to integrate geriatrics. We see this especially in oncology, but also in surgery clinics. There are models of geriatric consultation or geriatric HIV co-management with a few well-established clinics in San Francisco and New York. What most clinics will opt to do due to lack of access to a geriatrician is just start integrating geriatric assessments like our Medicare annual wellness visit. Some clinics go the route of focusing more on the internal medicine and set up primary care HIV clinics that are not geriatric specific, such as we see at Denver Health. There are also more novel models like embedding a geriatrics champion or telegeriatrics. All things people have tried, none that have proven particularly dominant over any other model. The one that's probably the least effective is the one that I do, and that's having a dually trained provider, which I love being, but there are so few geriatricians around and so few HIV providers around that it's definitely not a scalable model. I'm going to tell you about it anyway. So I started doing HIV and geriatrics care at the University of Chicago. Our clinic there is a Ryan White HIV/AIDS clinic with over 600 clients. 280 of those are over the age of 50. That's 40 more than there were 2 years ago when I left. And about 44% of patients are over the age of 50. This is a mostly Black neighborhood on the south side of Chicago. Most patients were male with about a 50-50 mix of strictly heterosexual men and men who have sex with men, a much smaller proportion of women in that clinic. The south side of Chicago, if any of you all are not familiar, does face a lot of hardship due to racism, with 7 of the 8 poorest neighborhoods in Chicago falling within the service area of this clinic. Despite that challenge, we achieved pretty high rates of viral suppression. Like 90% of our patients over 50 were virally suppressed. We had a 75% retention and care rate, which is pretty good, especially since this data comes from mid-pandemic. And it kind of reflects the thing that you'll hear over and over and over again from patients and patient advocacy groups, which is that it's not really about the HIV anymore. Like, we've kind of figured that out. 90% of us are virally suppressed. We're engaged in care. We're on meds. Like, that's no longer becoming our top priority or top problem. To try to meet the needs of all of these patients, there had been an attempt at a geriatrics consult clinic model in Chicago a couple of years before I had been there. This was primarily limited by geography. At the top is our main outpatient building located on the University of Chicago Medical Campus. Beautiful kind of Art Deco building where the HIV clinic is. But geriatrics were always special. We were located about 10 minutes south, or a 40-minute walk through the beautiful Jackson Park in the South Shore neighborhood. And that 10-minute drive difference or short bus ride difference was enough that patients were not interested in coming to see a geriatrician for consultation. Like, it just wasn't going to happen. And we didn't have space for a geriatrician at the time in the HIV clinic. So that had been a big barrier. In order to combat that, I set up shop in the ID clinic. We creatively called it the HIV and Aging Clinic. It was open to any patient 50 and up, and it could be either consultation from their ID provider or a transfer of HIV care and primary care to me. It ended up being about 50-50 with patients that I was seeing for consultation or for their primary care. That was in part because we had an older doc leave and many of his patients were older. But it was a great setup. We had on-site ID pharmacy, social work, and nursing all in one sort of giant break room. It was a great team collaborative effort with many of my team members there on the right. The median age of folks we ended up seeing in that clinic over the 2 years I was there during COVID was about 69. And there was a very high geriatric syndrome burden. So I was seeing lots of polypharmacy that had sort of gone unaddressed or unreined in. A lot of undiagnosed cognitive impairment, which was one of the highest concerns from providers referring patients to me. What patients were usually most concerned about was functional decline and falls. I'll put an asterisk there, not frailty. I was doing a lot of frailty assessments. Most patients weren't frail, but they were having horrible musculoskeletal problems or falling for other reasons. And then so a lot of osteoporosis is sort of the thing that was getting missed the most often. What I was doing was a comprehensive geriatric assessment featuring functional and fall screening, cognitive depression screening, med review, and a full frailty assessment using my handy dynamometer that I have since packed up and stolen and brought here. It's in my office if anyone wants to use it. What made this a nice model or kind of easy to get off the ground despite COVID is that I was just embedded in usual clinic workflow. So I had a 60-minute initial visit, 30 minutes for returns like all the other docs. It was MD only. I had the pharmacist and social worker and nursing support like immediately available if I needed them. They were on site at all times. Again, required no special equipment. I wasn't doing anything other than testing grip strength and measuring gait speed in terms of extra resources. It was also funded as an extension of the geriatrics clinic. So similar to what I do here at, for all intents and purposes, I'm just doing the same thing I do normally in seniors clinic, but in a different place. We had a lot of great successes, very high patient interest. I had heard over and over and over again the line, oh, no one's asked me that before. A lot of new dementia diagnoses, new dementia management strategies. We had really great pharmacy support for addressing polypharmacy. We had really great insurance and drug coverage support from our social work team when we ran into problems. And thanks to me knowing the folks working in all the nursing homes in town and having an LPN who had worked in a nursing home, we had some real great success stories with nursing home care coordination. That doesn't mean it was without barriers. I had a lot of issues getting people DME, getting people home health care. It was things that this team had never dealt with because most 40-year-olds don't need home health care. Also had a lot of struggle getting people to dementia services, either because they were off-site or not covered as part of the Ryan White program, or just completely unfamiliar to staff. And then a lot of problems getting patients into primary care or geriatrics, especially as I was leaving. Another big barrier is my lack of foresight on formal data collection. So you're hearing a lot of anecdotes right now. To try to address these barriers and sort of cement some of these successes of me being there, I was constantly on the lookout for how can we take those awesome geriatrics tools that we've already got and really like solidify them, especially if I'm going to be leaving. Like, we need to try to geriatricize this clinic as best as possible to help me do my job, help other people do their jobs, help our patients. So I approached this from the perspective of implementation science using what HRSA already has established, HIV/AIDS Bureau implementation science approach, sort of a clear-cut way to bring new interventions, new evidence-based interventions into HIV care. And what I saw and what the team kind of saw as our biggest gaps in care from that list of barriers and successes I showed you is really the dementia diagnosis and management. Like, this is where we were struggling the most. When people were diagnosed with dementia, which they weren't being diagnosed with dementia, We struggled with nursing home care coordination. We struggled with DME and home health care. We struggled with referrals to dementia services. Again, things that I really can't do on my own. And if I'm not there, then nobody's doing any of them. So this was sort of the inspiration for what's currently one of my bigger projects. Looking at it from more of a objective side, other than just, we feel like dementia is hard. We knew that we had a concentration of older adults on the South Side. We knew that there's a higher prevalence of cognitive impairment on the South Side. We knew that we had a lower ACP completion rate than the national average. We knew from surveys done by colleagues in geriatrics that 75% of community members on the South Side perceived dementia as moderate or major problems for their community. We knew from the failure of the previous program that geographic barrier was going to make it hard for there to be direct geriatric care integration. It was reliant on, again, a dually trained provider, which is not something that exists in many places. And then we had a high perceived education need from our social work team when I surveyed them about what do we need to do better in this clinic. So we had some hard numbers supporting this as our implementation target. I liked, though, some of the less formal data, which were questions that I got from other HIV care staff, like what's the difference between hospice and palliative care? Can HIV cause dementia? I've never been to a nursing home. How do they work? Am I allowed to call a family member if I'm concerned about someone's cognition? And then one that was actually more recent, which was, can I force someone to go on hospice? So there were a lot of qualitative evidence that we needed a little bit more help. So we've identified gaps in dementia care in our HIV clinic. Now we need to identify an existing intervention to try to solve it without reinventing the wheel. What I turn to is the the Dementia Champions Program, MME, from the NHS Scotland. This is a program that's been around since 2010, through which over 1,000 staff in NHS hospitals have been trained in dementia care. It includes principles of dementia care like legal aspects, communication strategies, working with caregivers, dementia screening. It's a 5-day interactive didactic program led by peers and dementia experts from that local area of the NHS. And the aim is just to take staff members of all walks, like schedulers, transportation folks, nurses, and push them to act as change agents in their area of influence. So if you're a transportation person in a hospital, how can you make that process more dementia friendly is the goal of this training program. They've seen a lot of success with it, and I like this quote from a government report, which is that a significant amount of change and improvement work has been initiated by these champions and would likely not have happened without them if we hadn't had all these people just motivated to make things slightly better for dementia care. What's nice about having an existing intervention is we already sort of had appropriate assessment criteria, demonstrated effectiveness, and core elements identified for this program because people had done the work. So what we created from that was the HIV Dementia Champion Program. This was open to any patient-facing HIV clinic staff at University of Chicago. We kept it at 10 training sessions, similar to the original program, but spread it out to make it more practical for outpatient workers. We did have to switch things to the outpatient setting by changing just a couple of the curricular topics. And we left it as a mix of didactic and experiential. So for some of these sessions, they were getting a 1-hour lecture from an elder law attorney in the area. They had a 90-minute meeting with a representative from the Alzheimer's Association of Illinois, or they were joining our geriatric social worker or one of our geriatricians in clinic and actually seeing things hands-on with people expressing that time in the nursing home was the most valuable thing for them. Other key adaptations, the original program had included e-learning that in their efforts of identifying core elements, they identified was absolutely not a core element. People hated it and didn't like it, so we just took it out. We also added additional training on hand because we want to try to make this as HIV specific as we could while keeping it applicable to general dementia care. And just like the original program, this ended with a clinical action plan. So we asked our champions to come up with a plan to make your clinic better, whatever that may be. We weren't putting them any pressure to do some massive QI or academic work. We're just like, come up with some idea to make things better, and we'll see where you take it. So far, we've got 2 champions trained. 3 more are in progress, wrapping up their training sessions next week. And so far, we've seen high champion satisfaction, highly rated acceptability and appropriateness using existing implementation measures. Really strong buy-in from our community advisory board who are all like, how can I help? How can I help? And we're like, well, we want you to help. We love that, but you don't work in the HIV clinic. You're not exactly our target audience. We're trying to find other ways to incorporate peers and community members into the dementia improvement efforts. And we strengthened ties to community partners. We discovered an Alzheimer's Association referral program that we didn't even know existed without this program. But my favorite feedback we've gotten so far is one of our champions was just relieved that the learning session was not a snooze fest, which when you're doing like educational work, that's what you want to hear, really. So we're wrapping up this evaluation phase and working on developing implementation toolkits. So our tools that we have right now are an implementation blueprint, curriculum, resource guides, assessment toolkit. We want to be able to hand someone working in an HIV clinic a packet to replicate this in other places so that we can get staff trained up in dementia care. It's a work in progress, being done in conjunction with 9 other sites. So more to come on that. So that is what I've done so far in Chicago and I'm still working on. Let's talk a little bit quickly about what we're doing here. So Colorado is a little bit different from Chicago. We have a much larger Ryan White clinic with about 900 clients over the age of 50, and 57% of patients in this clinic are over the age of 50, which is much higher than the Ryan White national average of about 45%. So we have a very old HIV clinic here. Most people are coming from Denver and Aurora. It's unlike Chicago, this is a much whiter population, mostly gay men. And what we've tried here before, shout out to Dr. Teets in the audience, is the positive aging consultation model. So I tried to set this up with Christine Erlinson before I went to Chicago. It was a geriatric consult visit model plus pharmacist medication review. Patients would come to the Geri clinic and see Scotty Church and then later Sarah for a geriatric consultation visit. We do have data on this. Most frequently addressed things were advanced care planning, osteoporosis, polypharmacy and other medication problems, and memory loss. But uptake of this program is pretty low. In the first 18 months, this is pre-COVID, we only had 11 patients that completed surveys for the program. I think we had about 15 total consults. So not great, despite the fact that these clinics are located 2 floors apart in the same building. To try to get around that, what I'm doing now is, again, I'm very creative at naming, I just stole the name, Positive Aging Clinic at the University of Colorado. So that's me as a geriatrician in the HIV clinic, again, for consultation or HIV primary care, open to folks 50 and up. I just hit my 100th patient seen last week, which was awesome. The mean age for this clinic though, thank you. Mean age is only 63. So it's a lot younger folks that I'm seeing than we had at Chicago, despite it being a much older clinic. So I'm seeing a lot of like 50, 55-year-olds in this clinic. And I have a resident working on formal data for this, thought ahead this time. But problems that we're seeing are very different than what I saw in Chicago. Here we have much more problems with polypharmacy, much more mood and psychiatric conditions, seeing a lot more like depression, bipolar disorder, schizophrenia, and substance use problems. Doing a lot more cancer screening and preventive care that's sort of fallen through the cracks. And then what I'm finding is more of a theme across HIV clinics is a lot of osteoporosis, a lot of sort of missed screening or incompletely treated bone mineral density loss. However, while I love what I do, and I think it's a cool model, and we're addressing a lot of needs, it doesn't really end with embedding a geriatrician. This is the same problem we had at Chicago. When we surveyed people, or I should say when Dr. Erlinson surveyed folks with a resident a couple of years back on what are your common barriers to care as an older adult living with HIV, it wasn't my osteoporosis isn't getting screened or I need a frailty assessment. It was, I need help connecting with resources. The wait time is too long. I can't get a hold of my provider. I can't get into clinic. This is both before and during COVID. And when asked like, what would be the most beneficial to your care, it was access to telehealth, not access to a geriatrician. Even though they all said a geriatrician would be great, and I would love if someone was in the clinic, that's not really where they identify their needs. They identify system-based needs, things that a provider is not going to be able to solve. So where I take it from here, we'll see. There's more to come. Again, we have a lot of evidence-based practices for implementation. We have all of these geriatrics tools that we could be using more effectively in specialty care clinics. To the right are just some of the things that we've got in the works right now. So QI efforts to improve osteoporosis screening, QI efforts to improve advanced care planning, getting a gait speed measurement tool in the clinic, Thomas. Um, I'm looking to replicate the Dementia Champion training program using funds from CDPHE with the AIDS clinical trial group, trying to increase older adult enrollment in clinical trials. We've got a lot of areas for improvement, very few of which are being led by me. I can't do all this work. I'm not that, you guys know me, I'm a little lazy. But just having a geriatrician around, like having that positive aging clinic model around has sort of served as a motivation for people to take up these initiatives and try to make changes for the better. Having the geriatrician really opens that door for not just clinical, but also research collaboration. And I encourage y'all, if you have a particular interest in subspecialty care, to find other places in which you can be that person pushing research and clinical care forward. And I will end it there for plenty of time for questions, with a lot of thank yous to all the folks here at Chicago and elsewhere who have helped make this possible. So big shout out to all these people, especially Dr. Erlinson. I will open it up then to questions.
Any questions, and feel free to enter into the chat. I'll share one from the chat and then I'll go back and look at the chat. So to what extent do you think that you are not seeing very much severe hand because those individuals are not receiving healthcare in general?
I don't think I understand the question.
Yeah, so I think like the question seems to imply maybe there's a bias in who has access to healthcare,
Yes.
and that those with severe hand may not be seen through the spaces where you would be able to see them.
Yeah, so those really are the folks who develop severe hand, is the folks who have not been receiving care. So when someone presents with dementia related to HIV, it is usually because they have had no access to care, they've been completely undiagnosed for years and had no idea, or there's been a massive lapse in care due to loss of housing, substance use, or some other barrier to taking medications.
Highly vulnerable population, yeah, that we perhaps do see, but then also maybe we don't see because people are truly so isolated.
First of all, thank you. This was incredible. I loved your presentation and the work you're doing. I wonder if you see a pathway to specifically collaborate with nursing home providers to kind of get us in the loop. I don't think that we're, understanding the barriers here, and I think that there would be incredible interest. So
I'm very glad you asked. I had to cut nursing home content because of time. The nursing home population living with HIV, though still small, is growing extremely fast, like much faster than HIV clinics. It's regional, so some states are seeing far more cases of HIV in nursing homes than others. And it's because folks are just aging into nursing home care. With nursing homes, we see underutilization of antiretroviral therapy. So if you look at claims data, it suggests that as many as a third of patients with HIV are not getting any HIV medications while in the nursing home, which is not ideal. We also see a lot worse stigma, both for LGBTQ patients in general, as well as like stigma from staff around HIV. While working in the nursing home in Chicago, I had people ask, like, can they be roomed with other people? Do we have to like do special precautions for people with HIV? So there's lots of room for improvement in education, but it's sort of a black box. There are like 5 big papers on HIV and nursing home care. There's not much out there. I did a poster a couple of years back looking at HIV training in nursing homes, and it's required in like 3 states. It's bad. So there's a lot of room for improvement. Sort of a pipe dream of mine would be to set up a referral network for nursing homes with HIV questions so that they had somebody to go to try to solve, especially medication access problems. But I don't have a good answer for how to solve it now because it's not great. One thing that we could leverage that we haven't been is that the vast majority of nursing homes have an ID specialist like on their staff because of infection prevention rules. So there's fairly good access to ID folks. We're just not really utilizing them well enough to take care of folks with HIV.
Thank you so much, Jacob. I have two questions. One is about, the access to these very complex drugs. I mean, the perception of someone, I went to Africa this past summer, access is easy peasy, right? Like weirdly easy. And I wonder if the same is true here. And if so, if you're able to kind of contrast that with other experiences of getting drugs we think are very valuable to people, but don't have these well-developed, well-run programs. That's question number one.
That is a constant fun topic of conversation at my house because my husband does lymphoma care where these drugs are many, many thousands of dollars. We have thankfully, partly through PEPFAR, like put money into HIV drug care. So it is actually pretty easy to get folks most HIV medicines. And if we can't get it through their insurer or through other government programs, Ryan White clinics act as, again, that payer of last resort, and through the AIDS drug assistance program can get anyone pretty much any HIV medicine they need. So it's not easy. We still have to, go through a bunch of paperwork, and we have pharmacists whose entire job is making sure people get their meds, but we can get them regardless of how much they cost for folks. The costs are also less extreme than you would think for many, say, cancer drugs as well, which makes it a bit better.
I mean, such a success, right?
Yeah.
Maybe you guys could write a paper where you're comparing and contrasting your practice experiences and why can't we do this for more, life-saving meds? Anyway, and then the second one is, have you had to do end of life care for your cohort yet? It's a young clinic, and what does that look like? And do you have recommendations for specific end of life care considerations?
I have not had to do a lot of end-of-life care yet, and that's again because most of these people are pretty young still by our standards. When it comes up, I think the biggest barrier I keep running into is that folks in the HIV world just aren't familiar with it. If they weren't practicing in nursing homes or in hospices in the 90s, it's sort of fallen out of use. An example I like to give is that the patient whose MRI I showed, because of his extreme slow thinking, after he enrolled in hospice, I was like, should I put him on Ritalin? Should I use stimulants? What should I do to try to just help pep him up a little bit while he's here on hospice? And the most recent paper I could find on this matter was from 1994. There just hasn't been much. So it like nursing homes, end of life care and HIV is a little bit of a black box, but I think other than needing to address some of the stigma, address especially LGBTQ health needs, it's really not all that different. Most people with HIV are not dying from HIV-related illnesses, so they can kind of fall into the same buckets as everyone else in terms of how we go about administering end-of-life care. It's just that many staff aren't familiar with any of those processes.
Along those lines, you had a slide that said hospice might be outdated in terms of care. What does coverage look like for patients on hospice for their antiretrovirals? And do they need to use Ryan White funds, or would that have to be concurrent care for veterans, or how have you seen that?
I've been doing it entirely on a case-by-case basis. Usually you can get HIV medications still covered through ADAP, the AIDS Drug Assistance Program, while people are enrolled in hospice. I have had hospice agencies pay for the drugs before. I think it's kind of depending on how much that particular drug costs. The general rule of thumb is that you should keep people on their antiretrovirals as long as they're able to take pills, because if you let virus start to replicate, they feel crummy and feel bad. And I think most hospice agencies recognize that and will usually work with you. But it's a big, confusing, messy gray area.
I have more of a systems question. So related to the Dementia Champion training, what are your thoughts on how we can encourage uptake and implementation of dementia, or more broadly, age-friendly principles, among a population of clinicians that are caring for individuals across the lifespan, and where, dementia is not, it's just one of the 20 things. It's not perhaps the biggest thing, although I think you are making a case for it's the next leading edge. So I think this is, your themes of how can we geriatricize specific parts of medical care?
The big selling points for the HIV Dementia Champion Program, or the things that have gone well, is like making it as easy as possible. So trying to make it as friendly as possible to the clinics, doing everything you can for them in advance, setting up as much of a detailed implementation blueprint as you can, making the training sessions as conducive to their schedule as possible. That has been one big area of help. Highlighting the linkages between the geriatric problem you're trying to address and what they see in clinical care has been huge. So highlighting some of the more complex dementia cases for our champions can help motivate them to take part in the program. And then trying to find the geriatric syndromes or geriatric problems that we work on that have a trickle-down effect can also be very helpful. So a big selling point for our staff with the HIV Dementia Champion Program is that they keep finding ways that they can help other patients. So in one of our champions in her feedback said, during my first session with the social worker, like I solved a problem I've been working on for 3 months for one of my 40-year-olds who was having issues with Medicare and Medicaid. That's part of the reason for my focus on dementia, is that I think if you can maximize dementia care, you're going to have a lot of positive downstream effects for anyone with functional impairment or other types of cognitive impairment. So trying to find making things as easy as possible, looking for low-hanging fruit, and then finding things that are going to have like a trickle-down effect or effect in other areas is probably where I would go if you're thinking about a new intervention.
Thank you. What a great discussion. Really appreciated that. There's a lot of connections that we'll make in follow-up by email with the older adult research specialists and research roadshows, and they will be at the LGBTQ+ hub. And so we will connect you for follow-up there. Thanks, everyone. Great to see you. You did great. Your pacing was wonderful. Hi. How do I turn this off? I need to find here. So once you turn it off. Yeah. Oh, there it is. Meeting controls.